This program introduces point-of-care strategies useful for critical care, disaster medicine, and public health preparedness worldwide. It is presented by the Point-of-Care Technologies Center, funded by the National Institutes of Health, and by the Point-of-Care Testing Center for Teaching and Research, founded in 1995. And this is Jerry Koss speaking. The program outline consists of 6 parts. First, an introduction to point-of-care testing. Second, use of POCT for acute care decision-making in rural settings and in the field. Third, lessons learned from recent major disasters. Fourth, the mission and philosophy of the Point-of-Care Technologies Research Network. Fifth, visual logistics, an efficient way to meet needs, and biosurveillance and preparedness. And sixth, recommendations for emergency critical disaster preparedness with integrated point-of-care testing. The next slide shows my book, Principles and Practice of Point-of-Care Testing, edited with contributions from numerous experts and published by Lippincott, Williams & Wilkins in 2002. Following that, Point of Care, introduced as a parallel companion journal in 2002 and edited by Dr. Kent Lewandowski at Harvard. Next, a more recent book published by AACC Press, to which we contributed a chapter on point-of-care testing. And I'd like to point out that there are several other publications that are useful from the same publisher. Let's start point 1. I will introduce point-of-care testing. I will define it, tell you the relevance of fast therapeutic turnaround time, and make a point about assuring quality irrespective of where testing is performed, even if that happens to be in the field for a disaster or in mobile uses. The next slide shows our toolbox with which we'll be working today. Starting at the top, clockwise, you can see handheld format, portable instruments, transportable on carts, benchtop, near patient possibly, applications of more conventional, larger devices. Then continuing, monitoring, which we term ex vivo, if the blood is sampled and returned, and in vivo if the probe is placed somewhere on or in the body. And finally, one of the most common forms, disposable methods. Point-of-care testing, as you can see in the next slide, is really intended to bridge the gap between empirical judgment and evidence-based medicine. Point-of-care testing is defined as diagnostic testing at or near the site of patient care. Please note that this definition does not depend on the type of instrument. The goals of point-of-care testing are to improve medical and economic outcomes and to decrease therapeutic turnaround time. Therapeutic turnaround time is the time from test order to patient treatment. Obviously, it wouldn't be worth using point-of-care testing if it did not improve medical and economic outcomes. The next slide shows you graphically that therapeutic turnaround time consists at the top of the time from test ordering to results receipt in red, then results receipt to treatment in yellow, and following treatment there will be a time interval until the favorable outcome occurs. Mid-slide, you see whole blood analysis or point-of-care testing speeding up the whole process, contracting the red and yellow intervals to approximately 5 to 10 minutes, and in most cases improving the efficiency of the entire care path such that the time to outcome is reduced as well. And this is a major advantage for point-of-care testing that nurses and physicians have found very attractive in their hard-pressed schedules to deal not only with critical problems, such as we'll discuss in this lecture primarily, but also more routine medicine where the volume of patients that they see is quite high. Well, the quality of point-of-care testing needs to be preserved in all cases. I often say point-of-care testing is simply not an excuse for poor quality or inaccuracy. Based on the concept of site neutrality, point-of-care testing should integrate the following characteristics: quality control, quality monitors, and proficiency testing into one patient-focused package that meets customer needs irrespective of where diagnostic testing is performed. Now, obviously, this is relevant to disaster care and field measurements wherever they might be made. We simply cannot sacrifice quality. The next slide shows you the kind of systems that are now integral to most point-of-care devices, providing security, validation, and performance controls. Somewhat like your ATM, most devices will require a PIN and password for operation. There can be emergency override. Moving to the right in the flow chart, quality control with action priorities is necessary to maintain performance and produce, further to the right, point-of-care test results with connectivity to the electronic medical record and various safeguards to assure that other things such as contamination of the patient or operator do not occur. The next slide is a Venn diagram showing that when we put the three of these together, security, validation, and performance requirements, generally speaking, it is effective in preventing errors. We will now address point of care for acute care decision-making in rural settings and in the field. We will talk about strategic use of point-of-care testing in the context of small world networks. Small world networks are like your family and friends. They are the smaller organization and assembly of people, devices, and healthcare services that allow direct primary care with acute care backup to work efficiently. We will caution this section about the effects of environmental stresses such as high or low temperature, the limitations and robustness necessary for devices and reagents. The next slide shows a map of central Thailand where there are several provinces, and centered at Pitsanulok, Professor Juan Visa, who studied in our centers, operates a mobile healthcare clinic, as you can see in the next slide, that delivers, next slide, primary care and diagnostic testing to several of the surrounding low-resource rural areas. Specifically, tests in this type of environment would include glucose, spun hematocrit, and others that are useful for screening and triaging patients. The next slide shows an area I've personally studied near the Mekong River and the layout of a small world network typical to such a single province. This particular province is Sakon Nakhon. The main city is shown by the star, and the various distances to the surrounding areas represent the small world network in a geography pretty much defined by mountainous terrain and the flow that has developed historically in that area. So this is what I mean by small world network, and by extrapolation you can apply the concepts of organizing point of care within a small world network to other geographic settings such as island communities, countries that have a larger span of control, or regions in which you have to operate yourself. Interestingly enough, the next slide shows a very advanced, small new technology for cardiac biomarker testing that I found in this small world network. The device actually not yet introduced in the United States. It does testing for troponin T and proBNP. The reason it is used is that within the small world network, it is very difficult to triage quickly patients that have acute myocardial infarction. And while the technology in the test packaging you see is slightly more expensive than that available on a large chemistry analyzer, this approach is very handy because the value of the information is important to the doctors and nurses for immediate diagnosis. And that is a theme that we'll see throughout point-of-care testing. Let me sum up the small world network concept then with an organizational chart showing at the bottom the spectrum of point-of-care testing and then the various grids of primary care units, PCUs, regional community hospitals, province referral hospitals, and the specialty center, as well as the mobile medical unit MMU, and the layout typical of these kinds of settings. Again, by extrapolation, one can design small world networks appropriate for island communities, for larger states like the state of California, which has adopted portable hospitals to become prepared for earthquake hazard, and so on. Now, as you can imagine, getting into these various settings, perhaps out into the field as well, with direct patient contact, requires that equipment be sound, robust, and able to withstand the temperature, humidity, and other kinds of physical extremes that may be found. And while I won't discuss the details of the next few slides, they point out the hazards of reagents that are not robust enough, such as those we have studied for glucose meters and blood gas measurement on a handheld device. So in summary of this section, if you look through the particular slides and the bar graphs, you will see the need for very careful handling, storage, transportation, and use of reagents commercially available at this time to do point-of-care testing in these types of settings. This study is in press to be published in Disaster Medicine and Public Health Preparedness. So the details are available there, and I'll simply end the section with an urgent alert. Disasters, environmental stress, and point-of-care testing. Exposure of point-of-care reagent test strips we found in cartridges for blood gas measurement to high and low temperatures can create inaccurate glucose and blood gas results. The degree of inaccuracy depends on the duration. The reagent strips are stressed. Manufacturers should produce point-of-care testing devices and reagents certified for use in disasters. Standards for performance and storage must be established through future research, and health professionals operating point-of-care instruments at disaster sites must consider these environmental limitations. And in fact, that is the bottom line for designing equipment packages and also for training operators who will work in first responder groups in a disaster situation. Next, let's look at lessons learned from major recent disasters. We studied the Thai tsunami, which occurred in 2004, and visited again in 2007 to see what changes had occurred in follow-up in the use of point-of-care devices. Shortly after the tsunami, the United States was hit by a major disaster, Hurricane Katrina, in 2005. And interestingly, studying that situation, we saw how it proved the feasibility of point-of-care testing in disaster settings in this country. But there are gaps. So we'll talk a little bit in this section about what we need but actually do not have at this time, and how to close the gaps. And as you probably have already surmised from the previous section, we really should have point-of-care testing devices that are more robust and that are properly certified for operation in the extremes one might find in disaster settings. Well, the so-called, in the next slide, pneumodemics phenomena means that we just have too many people clustered too close together, and when something goes wrong, it really causes quite a lot of damage. That leads to a huge health burden. We feel that organizing preparedness based on small world networks will benefit acute care, working in the demographic care unit, that is, the area where people are actually organized as an adaptive system. Point-of-care testing can lend nicely to preparedness because it helps minimize loss in acute crisis care. It does provide the entire clinical team, the physician, the nurse, the first responders with evidence on which to rationally base decisions, and as an adaptive system, it improves efficiency. Hence, we feel that leads to improved outcomes, and as one sets up and works with these systems in this complex adaptive system, one can assess cost effectiveness and make adjustments to optimize the actual value. And you'll notice in this lecture I use the word value more than cost because it is widely recognized that point-of-care devices are more expensive than traditional or factory-like automated laboratory tested performed in large clinical laboratories. But despite higher cost, the value of immediate diagnostic results is generally what makes worth implementation of point-of-care testing. The next slide shows you Phang Nga province in Thailand, southern Thailand, where the tsunami hit very hard. This is the area, in fact, we studied twice. The red zones are areas of major damage. The next slide shows the Kamala primary care unit in the background to the right. And amazingly, you'll see almost at the same elevation the Andaman Sea. So the tsunami rolled right in this area, and the inset photo shows how the people were trapped. Needless to say, it shut down virtually all care facilities in that area. The next slide shows a small community hospital typical of Phang Nga province, and this is the entire laboratory for that community hospital. For example, it is very limited. It has no ability whatever for measurement of blood gases, PO2, PCO2, and pH. Therefore, after in 2007, the tsunami, we found interesting that, as the next slide shows, the hospitals had adapted the use widely of oxygen saturation continuous monitors, otherwise known as pulse oximeters. We're going to make a couple points here with this slide, and that is, of course, these were gifts to the hospitals, the community hospitals in Phang Nga province, so they took what they could get gratis. But in fact, it is a principle that we would like to use consistently, the same sort of device, so as to make it easier for the operator, make it better and faster to check the calibration, quality control, proficiency testing, and other results from these kinds of devices, and to assemble a cost-effective package for point-of-care testing. The bar graph that follows shows just how many of these worked into various community hospitals, of which there are 4 in this province that we study. And the pie diagram that follows shows the huge numbers that the regional hospitals had. Takuapa on the left is quite close to the seaboard where the tsunami swept in and took a huge burden of the patients during this disaster. Phang Nga on the right is more central in location, but a larger and better established regional hospital. It's interesting to note that these devices were used after the tsunami and currently for ambulance transport of patients. And remember, while these large regional hospitals would have blood gas measurement as the specific example, there is none in the community hospitals, so they provided continuity of care using this kind of continuous O2 saturation monitoring. And therein we find a theme that comes from the small world network concept. There should be a continuity of diagnostic testing and the way that point of care tests are implemented throughout the region that one is responsible to prepare. Coming up to date with the next slide is a collage of various devices. The one in the top left is a picture I took myself in one of the community hospitals, a small handy device that goes on the finger, and then you can see various other continuous monitoring devices which also fall under the general category of point of care testing. The one on the bottom right is particularly interesting because it's a new device approved by the FDA in May 2008 for continuous monitoring of hemoglobin and the other variables shown. As we build this program, you'll soon realize there are quite an array and variety of different technologies at your disposal. And in fact, we'll see later how our Point of Care Technology Center is going to bring even more available to you and meet the needs as we can define them in the Point of Care Technologies Research Network. Well, let's look at the United States then with the next slide, which shows some of the areas hit and also the responses of various days around the state of Louisiana and New Orleans. Now, the upper right is what we would actually recommend under ideal circumstances, but not what was achieved. So looking at that timeline, we would see that point of care would be very useful in a disaster for immediate triage. And it would be portable, battery-operated, or unit-use disposal tests that are available to first responders. As the day progresses, then local rescue units equipped with more POCT would respond. Then, as the patients are triaged and transported, critical care analyzers and other larger point-of-care tests could be implemented, perhaps in mobile situations such as mobile hospitals or SNAP-2 sort of intensive care unit installations. And then, very much within the first week, disaster-specific mobile laboratories may arrive. And in fact, if you look at the timeline in the blue bars throughout this slide, you'll see that the response was not that quick. And in general, because of the fact that water occupied most of the terrain, the major portions of the response consisted of large ships and so on and so forth. However, in this setting, taken as a whole, point of care was proven feasible as a means to address a major disaster such as occurred in our own country. The next slide gives you some idea of the various point of care devices that were used by the armed forces, hospitals, and at evacuation sites, some that were donated such as blood glucose meters, and also the tests performed on these devices. You'll start to appreciate then that it's very important to establish actual needs. What will the responding team need to take with them? What tests will they do? And how will this address care paths and actual triage and diagnostic challenges? As the selection of devices is large and will just get larger and hopefully more cost effective. Next, we will look at the mission and philosophy of the Point of Care Technologies Research Network funded by the NIBIB at the National Institutes of Health. There are 4 centers: Johns Hopkins, Lawrence Livermore National Laboratory, UC Davis, which is our own, PATH in Seattle, and the University of Cincinnati. The basic philosophy is to design devices and test clusters based on needs assessment, and then to move them to the point of care through public-private partnerships. Our own center focuses on pathogen detection, new technologies, and transitioning of diagnostics to the primary point of care. And I will conclude this section with a note on micro versus macroeconomic point of care strategies. In the next slide, you'll see the assembly in general of point of care global opportunities, as those in the top left that would be applicable to disaster care, and the projects indicated there in the labs of Dr. Refson at UC Davis and Dr. Larson at University of New Mexico represent exploratory projects for new techniques in pathogen detection. The second of three components is our own point of care technology you see in the upper right as a portable field-ready device for multiplex pathogen detection. And we will compare these new emerging technologies to existing systems you see on the bottom of the slide, the reference instruments. The next slide shows you some of the philosophy of assembling test menus to address medical problems such as the medical surgery area, burns, immunocompromised host, transport of a victim or patient, and emergency blood donor screening. Specifically, as an example, Dr. Larson in his laboratory will be developing a technology that potentially could be used in the field during disasters to screen donors and rule out HIV 1-2, hepatitis B, and hepatitis C viruses. These pathogen test clusters and some of the details underlying them are presented in three publications you see cited in the bottom of the slide. The next slide shows you on the left the traditional way of collecting and then storing and letting incubate blood for microbiology laboratory culture. And on the right, the new instrument called Septifast that we've been using for PCR-based pathogen detection. The next slide shows you a Venn diagram from Dr. Richard Louie's work. He was in the picture in the last slide. Please consult that paper in Critical Care Medicine for details. But in summary, in his patients studied amongst critically ill patients at our medical center, PCR was more sensitive in detecting pathogens indicated by the red zone, and overall it represents a good technique to use in combination with traditional blood culture. The next slide then simply characterizes the design approach to this type of problem, using on the left the input of various types of samples to a modular represented by the different blocks instrument, which is our point of care pathogen detection platform. The ultimate goal in the upper right is to produce a result within 1 hour. Earlier I defined for you therapeutic turnaround time, so it means that from the time the patient or victim is first seen until treatment, we'd like to complete this process in 1 hour. Clinical modules could be those in the black rectangles, and at the bottom left again is our device repeated. The next slide shows that for biothreats and other sorts of problems, we would always want to direct them at fulfilling needs. So you see needs-based test clusters here for pandemics, viruses, natural disasters, etc. The next slide then introduces to you some of the design considerations for point-of-care testing. And when you are selecting these devices for your own disaster team or for preparedness in general, these become important considerations. On the left, you can imagine how a tube-based system would not deliver appropriate biosafety containment, and furthermore, in looking for some pathogens such as Pseudomonas or others that are in the environment already, could lead to, at the top where the instrument is shown, introduction of contaminants if there were an open sort of indirect administration of the sample to the instrument. In contrast, on the right, you see what we are considering now as a design for closed system with direct sampling and then direct coupling of the cartridge at the top in frame B. Another extrapolation of this then is whether you use coupled or direct blood sampling, as you see on the left, by means of a multi-purpose adapter, and on the right, a kind of one cartridge, one cassette fits all direct sampling, which then can interface to the instrument. So again, the point of showing you these are to introduce the future of point-of-care testing in terms of pre-analytical considerations. And these will be important criteria for any user who is in a program, public health program, for example, for preparedness in a given small world network, region, or state. In this country, particularly an island community such as Hawaii, where it would be important to select the instruments with these various design considerations in mind. And this slide now shows you cassette-driven PCR-based pathogen detection and commercially available systems that have not quite made it yet to the point of care, but are headed in that direction. And we show you them to give you some idea of the actual pathogens that can be detected on these systems, and also to point out in the bottom frames in both frame A and B that these are cartridge, somewhat contained systems designed to be flexible for future implementation. Then to summarize this section, let's take a step back and think of what is the funding program intended to accomplish at this point in time, and where will it go? Well, in essence, we would like to see a number of open architecture type systems where users could decide based on their needs which pathogens they would like to detect, and then work with the community of manufacturers to produce an instrument that's suitable for primary, community, and rural care. There needs to be a certain balance here in blending these technologies, and you might say from bench to bedside through the laboratory, so that we'll understand exactly what diagnostic therapeutic cycles are necessary in these acute care settings. And of course, I'm picking pathogen detection as a specific example, and in terms of threats such as avian influenza pandemics and so on, it's very important to understand the types of instruments that might be available in the future, and later I'll present some specific examples of biothreat instruments that are actually commercially available now. Well, in low resource and other settings, there may be non-instrumented or unit use solutions, and some laboratories such as the community hospitals I showed you earlier have no microbiology facilities, whatever, and they may be able to jump paradigms, that is, go directly to molecular testing to hit their clinical targets. We would like to prospectively shift medical practice to new nucleic acid detection paradigms, because we feel in the future these will be valuable clinically, and we're working, of course, to define sensitivity, specificity, and predictive value, or evidence-based medicine criteria for them, accumulating this experience now, and ultimately would like to see an appropriate value proposition for implementation with priorities and incentives for preparedness, disaster, and biothreat considered simultaneously. In this part of the program, we'll consider visual logistics, a term we use for selection and consideration of point-of-care devices that will efficiently meet your needs. And we will consider biosurveillance and preparedness. We'll do this by several visuals that present instrument formats, pre-analytical processes, platforms, and test clusters. In way of review, remember that we saw initially, when we first started, the relevance of fast therapeutic turnaround time, how when we move to the context of small world networks, this can become very important for triage and primary diagnosis of the patient. We learned from the Thailand tsunami and Hurricane Katrina the feasibility of point-of-care testing, but we recognize there are gaps. We're not perfect. Some settings might not have microbiology facilities available. Hence, in the next section on our center in the Point of Care Technologies Research Network, we focused on pathogen detection and needs assessment for it, and gave you some feel for actual design considerations. And now we'll look at a full range of devices that will illustrate what is available and might satisfy a broad assortment of needs for preparedness and critical care, but we must always bear in mind that these are, for the most part, commercial devices that, when subject to streams of environmental stresses, may not operate exactly correct. So one must perpetually keep in mind the total quality principle for point of care testing and ensure that the practice and application is done according to the specifications of the manufacturer. The first slide shows 3 types of disposable point of care tests. One could picture how important these are in primary care, but also possibly in situations where the infrastructure of the medical system has become damaged, such as power interrupted or some other problem associated with the small world network. The second slide shows 3 handheld point of care devices. The one on the left is a kind of miniature analyzer which does blood gases, cardiac biomarkers, limited hemostasis tests, and electrolytes, among others. The one in the middle is a sophisticated yet simple device for test strip measurement of glucose using an etched gold film with 4 electrodes to compensate for confounding factors that may be present in the sample, and this particular platform is being expanded to several other important tests for critical care medicine. On the right is a reminder. This is a picture I took myself of what I've found is probably the most ergonomic point of care device that I've ever had in my hand. Well balanced, set up, and on the bottom you see the pre-analytical aspects that are necessary to provide a sample to the test strip before inserted in the cartridge in the very bottom right frame. The next slide compares formats further. These are actually produced by the same manufacturer, the old on the left and the new on the right. This manufacturer is moving the test menu from biothreat agents you see on the left to 2 very difficult problems, MRSA and Clostridium difficile, and has a distinctively cartridge-based approach, as you see in the bottom frames on both sides. A brand new device in the next slide is the point of care hematology device, intended to measure white blood cell count, and on the right, complete blood count in a device still in evolution based on microfluidic sort of approach to flow cytometry. You might be interested to learn that I was recently on an FDA panel that considered the feasibility of making the CBC CLIA wave test. In this lecture, I have not addressed the regulations governing the use of point-of-care devices, but in any state in the United States or any small world network within that state, one wants to be sure to follow all applicable rules and regulations. The next slide is a collage of various devices intended to detect biothreats. The one on the upper right you've already seen. Its partner to the left is small, almost handheld, and then the others represent devices from direct application, bottom left, to what amounts to portable wet laboratories. The next slide details some of the approaches there. We compare first the one that we've seen before that is cartridge-based approach to the wet lab with a pouch configuration, so that now in looking at these test menus and considering the needs of the community and the needs of the small world network, one must take careful consideration of pre-analytical factors, the team, the training, and operational resources of that team to actually do testing like this. The next slide shows you more examples of select targets for diagnosis. On the left, a set of clinically relevant targets for everyday and esoteric testing. On the right, a system which duplicates its technology for clinical use, in this case for 3 biothreat pathogens. And again, we have compared, in way of visual logistics, the instruments on the top and the pre-analytical principles, that is cartridge, or how the samples obtained in the bottom frames. The next slide introduces to you open versus closed systems. This is important as your technology and resources may allow you to define the pathogen target, but on the other hand, if you're concerned about some of the most severe biothreats such as anthrax, Marburg, and Ebola, then a semi-closed system such as the one you see on the right may be of interest. The next slide emphasizes more the design factors. The system on the left is decidedly different from the one on the right, and the test principles are similarly distinctive. Point of care mobility is important, so now to emphasize that point, we have separated out of that general collage I showed you 2 of the devices to show you specifically the biothreat test menus that they're capable. So in summarizing this section of the program, we've used visual logistics to introduce different formats, sizes, shapes, and also testing from what would be considered routine, such as electrolytes, glucose, through the entire spectrum to very esoteric but important preparedness agents that may be presented to society as biothreats. This program concludes with recommendations for emergency critical disaster preparedness with integrated point-of-care testing. As you can see very clearly, the entire program is a work in progress. So is the technology, likewise the definition of needs, and as the years come up with new innovations and inventions, the way those needs are fulfilled will be quite interesting to see indeed. It is therefore a dynamic process that we are dealing with a very young field called point-of-care testing, so one would not want to think of the decision process or strategy thereupon as static. We know that point-of-care testing is proven in acute and critical care, and sometimes maybe the only form of diagnostic testing available. Worldwide, it represents an evolving standard of care. In this type of situation, a duality of routine and emergency rapid response testing improves cost effectiveness, therapeutic outcomes, and medical practice. By duality, I mean if one were to set up a program for preparedness, one would want also to be practicing that same program. Or as I say in the 3rd bullet, practice makes preparedness. Everyday use of point-of-care testing assures proper training, quality, and competency. Then in times of need, use the familiar instruments, cartridges, and tests as you select them to meet your particular challenges. Mobilize the team and go. But generally speaking, it shouldn't be the other way around, where the team is mobilized, goes, and then opens a box to find devices that are totally unfamiliar. Hence, in disasters, where we know point-of-care testing is feasible, and also, despite it being used frequently by disaster medical assistance teams, DMATs, and other rescue units, most commercially available point-of-care device agents are not yet environmentally robust. So that is a major caveat in the whole story here. If the devices are to be used, they must be used according to the specifications in the package inserts to assure that the tests will actually produce the results that are intended. In summary, perhaps a little bit negative, but nonetheless the reality, currently our nation is poorly equipped, ill-prepared, and too static for on-site rapid and dynamic diagnosis in disasters, biothreats, and pandemics. But then again, looking at a more positive standpoint, that is exactly why the National Institutes of Health are currently investing very heavily in the concept of point-of-care testing to roll out new technologies that will be available directly at the primary point of care. The next slide summarizes this sort of approach. The POC Technologies Research Network and its 4 thematic centers are designed to invent and innovate these new novel POC platforms, tests, and processes. And there is a separate funding program that started this year, which includes all 4 centers, with the intent of public-private partnering to distribute point of care and get it going commercially so as to reduce production costs and make it more feasible. We know fundamentally that optimal point of care testing for emergency and disaster care depends on both the speed and value of diagnostic information. Inexpensive and needs-based point-of-care testing platforms with test clusters assimilated into care paths should all be integrated regionally in the concept that I presented of small world networks for synergy of primary care and preparedness. In special geographically challenged situations, such as very mountainous terrain, the example I showed you earlier in Thailand of the small world network, or island communities, say, the concept of regional integration is particularly important, and it will have very strong impact on the selection of instrumentation, the design of the pre-analytical component, which I've illustrated with the visual logistics, and other factors involved in preparing the team appropriately. Lastly, badly needed low-cost molecular-based point-of-care technologies for pathogen detection, clinical, biothreat, and pandemic are emerging rapidly, and if funded adequately, as the NIH has started, will be within reach of island and other geographically challenged communities, acute care, first responders, and public health practitioners globally. Needless to say, this will change the positioning at the local and regional, global, or countrywide basis to be better prepared for the sorts of specific pathogen threats that we see potentially coming on the horizon in the next few years. This is Jerry Koss speaking. I thank you for joining the program. Have a good day.